Welcome to NP Certification Q&A, presented by Fitzgerald Health Education Associates. This podcast is for NP students studying to pass their NP certification exam. Getting to the correct test answers means breaking down the exam questions themselves. Leading NP expert Dr. Margaret Fitzgerald shares her knowledge and experience to help you dissect the anatomy of a test question, so you can better understand how to arrive at the correct test answer. So if you're ready, let's jump right in.
The NP sees a 74-year-old woman with a BMI of 30 who has a 30-year history of type 2 diabetes, hypertension, and dyslipidemia. Pertinent social history includes the following. She is a retired elementary school teacher who lives in a one-story house with her spouse and adult child. She is a non-smoker, drinks approximately 2 5-ounce glasses of wine per month, and walks approximately 2 miles per day. Her current meds include telmisartan, hydrochlorothiazide, rosuvastatin, metformin, semaglutide, and canagliflozin at optimized doses, and current A1C is 9.2%. And she is at hypertension and dyslipidemia goal. Prior medications include sitagliptin, with the patient stating, quote, "That medication didn't help my blood sugar at all," close quote. She states she's adherent to her medications and dietary advice. Her estimated GFR is within acceptable parameters, and she is feeling well. Physical exam is unremarkable. Which of the following is the most appropriate next step? A, advise that her A1C is at an age-acceptable level. B, add post-meal sliding scale rapid-acting insulin. C, prescribe basal and pre-meal insulin. D, add oral glipizide. The correct answer is C, prescribe basal and pre-meal insulin. Once again, it's important to go back to the pathophysiology of the disease. I like to remind people when they're getting ready for boards, it's almost always pathophysiology for the win, because it will lead you to the clinical presentation and then the appropriate intervention. Type 2 diabetes is one of insulin resistance coupled over time with pancreatic beta cell failure. What happens with this beta cell failure? Insulin release is reduced. Now, you may hear people say in the day of folks with type 2 diabetes developing, beta cell failure is likely waning, but at the same time, this person has had disease for 30 years and has not been able to take advantage of some of the meds that we now know contribute to the preservation of beta cells. In any event, what we have here is a situation where after literally decades of type 2 diabetes, she has a degree of beta cell failure. And that accounts for the fact that her glucose control is no longer in range. As I've said in other programs, you have to look at every single word in a question to make sure you get the point of the clinical presentation you've been given. She's adherent to therapy and therapeutic lifestyle interventions. If it says in the question, she's adherent, no second guessing on that one. As you will note, she is currently on semaglutide, aka Ozempic, a GLP-1 agonist that is a potent insulin releaser. She was also on a DPP-4 inhibitor, that was a sitagliptin, another medication that enhances insulin release. So she has now officially failed 2 insulin releasers. And yet, without any other identifiable causes, her blood sugars are elevated. This, coupled with her many decades of disease, tells me her pancreatic beta cell function is no longer sufficient to release enough insulin to maintain a euglycemic state. What are the guidelines for adding insulin to type 2 diabetes therapy? One of the main reasons is just what we're seeing here, an older adult, decades of disease, who is now failing to achieve glycemic control with one or more insulin releasers. And it needs to be said, the GLP-1 agonist, something along the lines of semaglutide, or a GLP-1 agonist like tirzepatide. These are simply the most potent insulin-releasing medications around. And if people can't release enough insulin on one of those drugs, then it really tells you the pancreatic beta cells are just not working properly anymore. I know this seems like a good deal of work to unpack when answering what looks like a fairly cut and dry question on next medication in type 2 diabetes. But these are all the points you have to consider when answering this or any other board question. Remember, you're now a prescriber. That's an entirely different role than the one that you have played as an RN. With this as background information, let's take another look at the question. The NP sees a 74-year-old woman with a BMI of 30 who has a 30-year history of type 2 diabetes, hypertension, and dyslipidemia. Pertinent social history includes the following. She's a retired elementary school teacher who lives in a one-story home with her spouse and adult child. She is a non-smoker and drinks about 2 5-ounce glasses of wine per month and walks about 2 miles every day. Her current meds include telmisartan, hydrochlorothiazide, rosuvastatin, metformin, semaglutide, and canagliflozin. So let me just take a little sidestep on this one for a moment and go over the different classes those meds are in. Telmisartan, ARB, hydrochlorothiazide, thiazide diuretic, rosuvastatin, obviously a statin, metformin, insulin sensitizer, semaglutide, GLP-1 agonist, insulin releaser, canagliflozin, an SGLT2I, and glucose offloader via the kidney, all at optimized doses, and her current A1C is 9.2%. She is at hypertension and dyslipidemia goals. Prior medications have included sitagliptin, DPP-4 inhibitor, with the patient stating, quote, that medication didn't help my sugar at all, close quote. She states she adherent to her medication and dietary advice. Her estimated GFR is within normal limits, and she is feeling well. Physical exam is unremarkable. Which of the following is the most appropriate next step? A, advise that her A1C is at an age-acceptable level. This, of course, is incorrect. She's an older adult with type 2 diabetes. It might, underline the word might, be acceptable, particularly to avoid hypoglycemia that is very dangerous in older adults, to have an A1C parameter as high as 8%, but 9.2% is too high at any age. B, add post-meal sliding scale rapid-acting insulin. This is what I call an answer that, of course, is incorrect, but might seem appropriate if you're reflecting on your inpatient role as an RN. What you often see in the inpatient setting, and it's often referred to as sliding scale insulin, which it isn't. It's actually correction insulin used in the acutely ill adult. In other words, this is used to correct an elevated blood sugar. So let's say that, for example, you had a patient with diabetes who's 65 years old, hospitalized with pneumonia. They usually have wonderful glycemic control, but now because they've got pneumonia and the stress on the body, the blood sugars are all of a sudden way out of range. Sometimes what is referred to as sliding scale insulin is given. It shouldn't be called that. It should be called correctly correction insulin. Long and short, sliding scale insulin will never, repeat, never be the correct answer on the NP boards. Got it, folks? Yes, never the correct answer. Why? Because particularly in the day-to-day, this is a reactive way of treating hyperglycemia. Will allow the blood sugar to rise, then chase it down with insulin. So correction insulin to an acutely ill person, perfectly acceptable. Needs to be monitored very carefully, but it is done. It's acceptable. Day-to-day sliding scale or correction insulin, never correct. This is a reactive way of treating hyperglycemia. It is dangerous, creating significant hypoglycemia risk, in addition to allow the blood sugar to swing way, way, way high, creating a difficult situation for the body. The target organs of type 2 diabetes, such as the kidney, the brain, the heart, and the peripheral nervous system, will be excessively exposed to periods of hyperglycemia, which can accelerate diabetic target organ dysfunction. C, prescribe basal and premeal insulin. This is, of course, the correct answer. She's been tried on 2 insulin-releasing meds, a GLP-1 agonist and a DPP-4 inhibitor. And as I mentioned before, GLP-1 agonist is one of the most potent insulin releasers around. Even with this, she's been unable to achieve glycemic control with no particular worrisome changes in lifestyle. Med adherence or anything else along those lines, it seems like she's staying the course with what she has done with her type 2 diabetes. She's at a point in her disease where her pancreatic beta cells are likely not releasing sufficient insulin to maintain euglycemia, and therefore she's at a point where what she needs is insulin replacement therapy. As an aside, the addition of basal and premeal insulin needs to be done carefully to avoid hypoglycemia and with considerable amount of patient coaching. This is where certified diabetes educators prove to be worth their weight in gold. Because remember, we often think we're the nurse, we can do all the education. Yeah, we can. We can do a lot of it. On the other hand, we don't have half-hour, hour-long visits in our schedule as a general rule, like a CDE would. And we don't have the schedules to see patients that are often as open as a CDEs would. So this is where we want to involve a certified diabetes educator. And one thing to keep in mind, if you're part of a larger healthcare system, the CDE might not be an RN. It might be a pharmacist. It might be a nutritionist. There are a number of different people who are educated as CDEs. D, add oral glipizide. This is also incorrect, of course, because glipizide is a sulfonylurea. It's an example of another insulin releaser. She has failed insulin releasers. Trying another one is not going to make any difference in her clinical outcome. Key takeaway: evaluation questions as defined by ANCC and AANP focus on the patient's response to care. This requires the NP to determine if therapeutic intervention has been adequate or needs to be adjusted. In order to answer these questions correctly, and these are up to 1 in 5 exam questions on the boards, knowledge of the course of a given disease is critical.
Thank you for listening to NP Certification Q&A, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com.